we can start the second session. And so, as I said before, this will be about uterus and tubes. And Jean-Paul will start with the uterine malformation.
See? Okay, so wait just 1 minute. So I will start with ultrasound diagnosis of congenital uterine malformation. It's a very heavy issue. I will try to do it the easier I can. I have no disclosures, and the learning objectives are to understand the pathophysiology of uterine malformations, to understand the uterine malformation classifications, to know the diagnostic techniques available for uterine malformations, and to learn how to perform a 3D ultrasound for the diagnosis of uterine malformations. Uterine malformations are the result of a failure or interruption of the development of the female reproductive system during embryogenesis. If it happens at 6 weeks, it will affect the formation, so it will be an agenesis or a unicurrent uterus. If the failure occurs at 7 or 9 weeks, it will affect the fusion, so we will have bicornuate uterus. And if the failure occurs from 30 weeks to 18 weeks, it will affect the reabsorption, so we will have septate uterus or septate cervix or septate vaginals. The incidence of uterine malformation are in general population around 6%. Infertile patients is higher, 9%. In recurrent pregnancy loss is higher, 40%, and the higher incidence is in patients with infertile and that have a recurrent pregnancy loss, with almost 25% of incidence in uterine malformations. Greenpeace in this study conclude that the most frequent uterine malformation is the septate uterus, followed by the bicornuous uterus and the arcuate uterus. In ASRM 2013, Dr. Angela Palumbo presented this study about the incidence of uterine malformations, comparing the incidence of uterine malformation in infertile patient cases with general population the controls. And uterine malformation were significantly higher in the infertile patients, and the more frequent malformation observed was the partial septum uterus. And in a second analysis, comparing infertile patient cases with fertile control, patients that have already pregnancy, the difference was really higher. Classification. I will mention the different classification that we have for uterine malformations, but we'll analyze them with more detail using some examples at the end. This is the first American Fertility Society classification for 1988. I won't go deep into it because we have a new one. So, and this is the ESHRE classification for 2013. This classification, we can see the normal uterus, the dysmorphic uterus, T-shaped anarchoid uterus, the septate uterus, the bicorneal uterus, the unicorneal uterus, the aplastic uterus, and the unclassified classes. And in the extra classification, they have a separate classification for the cervix, normal cervix, septate cervix, double cervix, and another part for vaginal malformations. This is the ASRM classification from 2021. It differs from the first. The classes doesn't have numbers, and they're classified by the name that we usually use with all the variants. So we have 7 big groups. We have the agenesis group, the unicornate group, the septate group, the Delphis group, bicornate group, vaginal septum group, and the complex group. This is the best way. It looks very difficult, but if there's 7 groups that we have. And it also, this classification has a web tool. If you scan this code, it will take you to the web tool. It has interest application. I recommend you to try it. When you select the malformation, you can see the different variants similar to different diagnosis, the symptoms the patient will have, images to guide us what type of images we have on sonogram, MRI, and recommendation for the treatment of this type of malformation. So I recommend you to try it at home. We know the classification, but how to do the diagnosis? What should we use? The gold standard is laparoscopy plus hysteroscopy. At the past, as Dr. Apalumbo says, it was used for classification of some malformation, but now we have less invasive tests to do the diagnosis. We have 3D ultrasound, sonohysterogram. These are the uterine malformations diagnosis tests that we have. The hysterosalpingogram, 2D or 3D normal ultrasound, 2D or 3D sonohysterogram, and the MRI. So let's compare sonohysterogram, 2D ultrasound, and 3D ultrasound. The compare of 2D ultrasound and 3D ultrasound, we have a lot of studies about it, and they conclude that sonohysterogram, 2D ultrasound, hysteroscopy are suboptimal because they do not visualize uterine contour. 3D ultrasound has a higher sensitivity and specificity for the diagnosis of uterine malformations. In this study, Ludwig, they observed that 3D sonohysterogram has 100% of accuracy in the diagnosis of uterine malformations, with a normal 3D 97% of accuracy, with a 2D sonohysterogram a 94%, with a 2D done by an expert, the accuracy was 90%, and a 2D transvaginal not done by an expert, the accuracy was 78%. In this study, Salum analyzed the reproducibility of 3D with 2 operators, and they found the kappa index was 0.97. That's good. Really, it's really good, because when we have kappa index above 0.9, in this case 0.97, is almost perfect the level of agreement. So we have a very good reproducibility. And what about MRI? MRI, we have many studies about uterine malformations. We have a sensitivity and a specificity around 100%. The problem is the cost and the accessibility to these tests. I think it should be reserved to other types of pathologies or some specific uterine malformations, because we have 3D ultrasound, and we will see how to do this diagnosis with this tool. If we compare 3D ultrasound with MRI, we have these three studies that conclude that 3D ultrasound and MRI have very similar sensitivity and specificity for the diagnosis of uterine malformations. Graupera, using MRI as a gold standard, compare the 3D ultrasound, and it has a kappa index 0.095, so has an excellent strength of agreement with the different class of malformation. So 3D is very good for the diagnosis of uterine malformations. And for the patient, 3D ultrasound will be more cost-effective, more accessible, more comfortable for the patient, quicker, easier, and very accessible for gynecologists to do the 3D ultrasound. What are the recommendations for doing a 3D ultrasound? I will give like 3 recommendations that we normally do to uterine malformations. 3D ultrasound, that if we do a normal 3D ultrasound, we do it in luteal phase, so we can see very good the uterine shape, the endometrial shape. With 3D sonohistogram, when we do it, we try to do it in initial proliferative phase or with birth control pills, and do it with an empty bladder. It's very easy. We do theta rotation in B, theta rotation in C, and we have coronal plane, and then you can do the BCI 2 to 7 millimeters, and you have a perfect view of the coronal plane for doing the diagnosis. Now we will see some cases to try to understand how to do the classification of the uterine malformations. This is the case 1. We can see in this case there is a septum. So what we should do, first of all, draw an intercornal lane from one cornal to the other cornal. This is the intercornal lane. After that, we measure the length of the septum from this intercornal lane to the fundal part of the endometrium. Okay, the endometrium, the fundal part, this will be the length of the septum. After that, we have to measure the length from the intercornal line to the fundus. So if the septum is bigger than the distance to the serosa, here we can see that this is bigger than this, we're talking about a septated uterus in Escher classification. Okay, so when we go to the septate uterus class, and then what we have to see is a partial or is a complete septum. It's a partial septum, so it will be in the Escher classification U2A, a uterine malformation. After that, we see the cervix. Have a normal cervix. It will be a U2A C0, normal vagina C0. This will be the Escher classification here. The ASRM 2021 is a little bit different. They define a partial septate uterus like when the length of the septum is more than 1 centimeter and the angle is less than 90 degrees. They define a normal or equate uterus when the length is less than 1 centimeter and the angle is bigger than 90 degrees. And they define as bicornuate uterus when the serosa indentation is more than 1 centimeter. So the same case with the ASRM classification from 2021. Here we have the septum is more than 1 centimeter, and then we look for the angle. It's less than 90 degrees. So we're looking at a partial septate uterus. Here we have other case. This case 2, we can do the same. Intercorneal line, we measure the septum length and the distance to the serosa, and we can see that the septum is smaller than the distance to the serosa. So in the Escher classification, it will be an arcuate uterus that is classified in the dysmorphic uterus in the others. So it will be a U1C. And the cervix, it will be normal cervix, for example, and a normal vagina, so it will be a U1C, C0, B0. Same case, ASRM classification 2021. We have a septum that is smaller than 1 centimeter, and the angle is bigger than 90 degrees. So we are classified this uterus as a arcuate normal uterus. This other case, we can see here, we have 2 ME uterus. It is a very good defined indentation here. So how we classify this uterus? With the Escher classification, it will be a bicorporeal uterus, the third class, and it will be a complete bicorporeal uterus. So it will be U3B. After that, this patient have 2 normal cervix, so it will be a U3B C2 with a double normal cervix, and this patient have a normal vagina, doesn't have any septum, so it will be a V0. At the end, it will be a U3B C2 V0. When we go to the ASRM 2021 classification, it will be the Delphis uterus, the group of the Delphis uterus, and the only thing we have to see if it have a longitudinal vaginal septum, longitudinal or partial or not. This uterus is the Delphis uterus without a vaginal septum. This other case, case 4, we can see only one left ME uterus here. So in the Escher classification, it will be ME uterus, the U4 class, and it doesn't have a rudimentary cavity, so it will be a U4B. If you have a normal cervix and a normal vagina, it will be a U4B, C0, B0. And for the ASRM 2021 classification, it will be a unicornate uterus without rudimentary cavity, and they classify left or right. In this case, it will be a left unicornate uterus. This fifth case is a T-shaped uterus. We can see a T-shaped cavity here, but with a normal external uterus. So in Escher classification, it will be a dysmorphic uterus with a T-shaped uterus. It will be a U1A. And with a normal vagina, normal cervix, it will be C0, UV0. T-shaped uterus have no classification in ASRM 2021. I think it should be, because as we talked before, maybe there's no implications of this type of uterus in the prognosis, of maybe we don't have to do the surgery, but we have to classify, because this type of uterus are different, and maybe it's important, maybe not. But if we don't do good classifications and everyone have the same classifications, we won't know if it's important or not. The better two classifications are the American and the Escher, but in the ASRM there's no classification for T uterus. There are other specific classification for T uterus, but it are not in this type of classifications. So take-home messages are that 3D ultrasound is a fundamental tool in uterine malformation assessment. 3D sonohysterogram and MRI are the best diagnosis test. 3D sonohysterogram is the most cost-effective test that we can do for 3D malformations. It's more accessible, more comfortable for the patient, and at the same time we can assess uterine cavity and fallopian tubes. Classifications, I think they are very complicated, controversial, and there should be an agreement between ESRE and ASRM to use a single classification. And that's all. Thank you.